Dear colleagues, dear friends, it's my pleasure to moderate again this new webinar organized by the NSQLB section and dedicated today to update our knowledge on pituitary tumors. We have, as always, a very interesting panel of speakers. We will start first with Emmanuel Joanneau from Lyon, who will discuss with us the medical management on aggressive PNETs and craniopharyngiomas. Then Julia Kozu from Lausanne will discuss with us PDL1 expression in PITNET. Then Henri Schröder from Greifswald will discuss the endoscopic endonasal resection of aggressive adenomas with cavernous sinus invasion. Then Luigi Cavallo from Naples will discuss the rare cellular lesions. And finally, Diego Mazzatenta from Bologna will discuss the pituitary surgery in elderly patients. But before starting, if you agree, I will make just a small announcement over a symposium, a very interesting symposium that we organized in Brussels in September 7 to 9, over many topics, including skill-based topics with the participation of many members of the ENS skill-based section. Most of them are today with us. So if you would like to have face-to-face discussions and also in-depth discussions on several topics, please be welcome to join us in Waterloo for this very, very interesting event. So we will start with Emmanuel. Emmanuel, I'll give you the floor. Please, we'll be interested.
Okay, so okay. I share.
Hello, Luigi, that I see joining us.
So you can see my screen?
Yes, but not in full screen mode.
That's good.
It's not, I see two slides, the main one and the second one. Yes, it's perfect.
Okay.
Yes.
So we can start. Good afternoon, everyone. It's always a pleasure to be and to talk about pituitary tumor. So my topic was will not focus on surgical approach. I will talk about medical management. There is a lot of new data, progress, and surgeon, if it's not directly a surgical topic, pituitary surgeon and surgeon who are interested in that for that kind of tumor need to be aware about medical treatments. So we talk first about PITNET. The PITNET, you all know that it's the new name of pituitary adenoma. So you can find both in the literature. So the definition of an aggressive PITNET, you all know that in most of the case, the pituitary tumor are benign tumor, but there is a small percentage and of PITNET who are aggressive and will recur after traditional management, surgical or medical therapy or radiotherapy. So that's the definition of aggressive PITNET, progressive disease despite optimal standard therapy. And there is a small, very small percentage, around 0.2% of pituitary carcinoma. And pituitary carcinoma, the definition is when you have a metastasis, it can be in the cranial space or the spinal space or outside. So for this kind of tumor, it's not the current treatment we all know. Whatever the tumor are secreting or not. And when you have a tumor that progress, recur after surgery, radiotherapy, and medical drugs, the first medical option, and now you all know that, it's temozolomide, like for glioma. Exactly the same protocol, around 200 milligram per meter, 5 days per month, And you will use this kind of approach, and you will try. And you can see here that there is a strong response, and it works well in some patients. And the first evaluations, you start this kind of therapy, and the first evaluation of your patient will be after 3 cycles. I mean, when the patients respond to therapy and to temozolomide, you can see that after 3 cycles. If you don't have any response, either biological or tumoral response, after 3 cycles, the patient will be resistant to temozolomide, and you have to change the treatments. In responding patients, if it does respond after 3 cycles, you can continue the protocol and the therapy, and the next evaluation will be at 6 months. And after, the question you will have to face, it's the longer of the treatment, because some patients respond well, like in this case. You have the level of, it was a resistant proactinoma. You have a tumoral management, but you have also a secreting marker in the blood. And you can see here, you initiate your temozolomide treatment, the proactin level decrease. There is a good MRI response. And the question is how long you have to treat your patients. And there is no good answer at that point. So when you consider all the series in the literature, the temozolomide efficacy, you can see its aggressive pitnets are in most of the case secreting pitnet, corticotroph, lactotroph mainly. So you can check the blood sample. You can also follow the patient with the MRI. And when you consider, and there is a lot of paper on that, especially from my endocrinologist, Gérard Ravo, and he performed a European survey with the European Society of Endocrinology. And what you can see here is the response for all patients, including secreting or non-secreting, because there is few percentage of non-secreting gonadotroph aggressive pitnet. And you can see here the complete response is around 10%, a little bit less, 1/3 of partial response. And there is many patients who did not respond to therapy. So it's worked well, but it is not working for all cases. So you can see here exactly the same. When you have a good response, but it's a partial response, you can continue the temozolomide. When you have a complete response, it's this situation you can stop the temozolomide treatment and follow the patients. And when the patient did recur, the literature shows that you can try again a second course of temozolomide, but it's the response is less efficient. So the question is, when you have a complete response, you cannot maintain for long the temozolomide treatment, so you have to stop. But after, when you have a recurrence, a tumor recurrence, you start again temozolomide, but you cannot expect the same efficacy. So the first option, it worked well. It's around 40% of response when you look at all the series. But for the other, when you have a recurrence after temozolomide and resistant to temozolomide, you have other now options. And there is many treatments that have been tried so far. There is peptide receptor, because you all know that there is some receptor on the tumoral cells, especially somatostatin receptor, and you can try a peptide receptor radionuclide therapy, you put a radionuclide on the peptide that will be fixed on the somatostatin receptor. It's all the treatment you can see here. But when you look, it's in situ radiotherapy. And when you look at the literature, there is very few and small cohorts, and it doesn't work well. I mean, there is, when you look at the response on this flow chart here, there is only 3 partial response, no complete response, and most of the patients did not respond. So it has been tried, but so far there is no real interest or good result using this kind of approach. Anti-VEGF therapy, it's another treatment you can try because in many cases the pitnet express or overexpress VEGF and VEGF receptor. So here is the literature. You can find small cohorts secreting pitnets, some very few non-secreting. And here is the response you can expect. Only one, there is 17 case in this series, and only one complete response, some partial response. So you have positive results using anti-VEGF therapy. It's about half of the patients who did response, and we will respond to such therapy. So it's the other option you can use when you have a resistant, a recurrent tumor, when you use temozolomide at the first time and there is recurrence, you can think about using anti-VEGF therapy. Tyrosine kinase inhibitor, it's all the oncologic pathway you can find for the other kind of tumor, and the other drug you can try, and that's work for some other tumor. So you can use tyrosine kinase inhibitor. There is no impressive result with such a therapy. Only one partial response in a series of little bit more of it's 12 patients. So there is no great result, no impressive result, but it's always the same issue. You have only small cohort because aggressive pitnet of pituitary carcinoma do not represent a large populations of patients, hopefully. mTOR inhibitor, it's the same. You can, there is some patient who benefit from this kind of approach without any response, but only 6 patients. So it's not very impressive. The new approach is with immune checkpoint inhibitor, and Julia will talk about that later on. I'm not an immunologist, only I will give you some data for surgeons. On the T cells, for the immune response, you need T cells that will kill tumoral cells. On T cell, you have some receptor, PD-1 and CTLA-4 receptor. And when you, there is a link in this receptor, the T cell will die, sorry, and you depress the immune response. So it's very simple. And you all know that the tumor manage expressions of ligands. There is PD-L1 ligand on the tumoral cells or in the some cells that present the antigen, and the overexpressions in the tumor by the tumor of this kind of ligands that lead to activate the programmed cells of T cells and depress the immune response. So it's very simple. There is some kind of receptor, that's the immune checkpoint. When you link and when the tumor cells link to this kind of receptor, that's lead to the death of the T cells and depress the immune response. So the immune checkpoint inhibitor are drugs that inhibit either this kind of receptor to protect the T cells, or inhibits the ligands that are expressed by the tumoral cells, trying to enhance the immune response to the tumor. So there is some drug, and especially two kind of drug, the PD-L1 receptor ligand, or the CTLA ligand that to protect T cells. So there is drugs, and there is now interesting result for this kind of approach, either for recurrent intracranial tumor with metastasis, like in this case, or systemic metastasis, like in this case, it was a liver metastasis, and there is the result after the immune checkpoint inhibitor treatment. So we can use only one drug or two drugs. It was here in the corticotroph secreting pituitary carcinoma. So when you look at the results, and my coworker, Charles Ravro, made the survey at the national and the European level. So there is, I will be more fast. It was a combinations. So when you look at the series, it's mainly secreting pituitary pitnets, aggressive pitnet or pituitary carcinoma, pituitary carcinoma. And when you look at the results about the tumor response, you can see here the corticotroph pituitary aggressive pitnet or pituitary carcinoma are more responding than lactotroph tumor. And there is a very interesting result. It's always tumor that are resistant to all therapy you can use, and after temozolomide. So it's the last change. So you can see here, there is partial response and in both cases, and 1/3 of the corticotroph aggressive tumor did response to therapy. So it's exactly the same when you look at the biochemical response, the ACTH or prolactin level. So there is complete response and partial response, and there is better response for corticotroph than for lactotroph. So it did work. Very few adverse events, very few treatment that need to be stopped because of morbidity. So here is it is it's only a very small cohort, but it's quite interesting. So the more large cohort is this one. 16 corticotroph, 8 lactotroph, and it's always the same. Corticotroph did response better with more only one complete response for corticotroph, no for lactotroph, and there is partial response in a little bit more than 1/3 of patients for corticotroph pitnet, aggressive pitnets. So which is also interesting, that pituitary carcinoma did response in a more efficient manner than atypical pitnet. So and it's work in the cranial recurrence, and it's work also for systemic metastasis. So that's very interesting. You need to combine the two drugs. It's better to combine the drugs than to use monotherapy, but there is no strong data at that point, and that's need future studies. So I will skip. So for aggressive pitnets, when you have tumor that are resistant for all treatments, You start with temozolomide, free cycle. If it did work, you continued with 3 more cycles. If there is a complete response, you stop and you follow the patients. If there is no compressed response, partial response, you continue temozolomide as long as efficient and tolerated. And if there is no response at all, so the second option, the second line, is to use IMIN inhibitor checkpoints or anti-VEGF therapy. So it was the first part. So there is more and more study about that topic, and it's also the same approach with craniopharyngioma. You all know that now there is more and more study about molecular biology in craniopharyngioma. Craniopharyngioma is always difficult tumor, especially when there is an hypothalamic invasions. And you need to be aware about the new molecular data and the new medical approach that can, in some occasion, replace aggressive surgery. So you all know that for papillary, you have 2 kinds of craniopharyngioma, papillary, 10% in adults. And there is, there is a BRAF mutations on papillary craniopharyngioma. In almost all papillary, it's in between, it's around 95% of papillary craniopharyngioma that have the mutation, the BRAF mutations. So it's very frequent. And the second type of craniopharyngioma is adamantinomatous craniopharyngioma. It's the more frequent craniopharyngioma you can find, and there is some mutation that's CT-NB1 mutation that lead to beta-catenin accumulation in the cells and to activation of oncologic pathway. So it's far more complicated than that, but you have just to know that there is a mutation. It's approximately the same percentage of the ACP that bear the mutations. But this mutation, we don't have any efficient treatment on that. So when you look at the molecular biology, what you can see here is that there is an overexpression of EL6 and EL6 receptor, especially in the cystic component of the tumor, and overexpression of VEGF. And you have also the expression of the checkpoint in the same, it's exactly the same that for PITNET. So you all know that now we have target therapy for papillary craniopharyngioma. You have BRAF and MEK inhibitor. It's the same pathway. And when you use combined treatment, it's very efficient. The first case report was in 2015 by Brastianos. Here is a reprint from my colleague Rostami. It was a recurrence after surgery, after radiotherapy. You can see here the tumor recurrence. It did respond well to treatment, but when you stop the treatment, the tumor recurs. So it's not a curative approach. So we use this kind 6 years ago for this patient. It was a papillary. I operated first using a non-nasal approach. There was a small tumor remnant, very sticky to the chiasma. And there is a very fast recurrence after 6 months, symptomatic recurrence. I don't want to reoperate the patient, so we use the target therapy just to decrease the size and the volume of the tumor. It's worked well, it's very fast. It's always like that. The first response was 2 months, 50% of tumor reduction, volume tumor reductions. And after 5 months, 90% of tumor reductions. And after we send the patient to the radiotherapy with the small targets. and the patient is totally free of tumor now. We use also this kind of approach with a new strategy. It's neoadjuvant treatment. Here is in this case, this tumor cannot be removed without morbidity for the patient. It's infundibulotuberal tumor with hypothalamic invasion. So it was a HTA patient. So we can think about lymphoma. So we did perform a first biopsy, and the biopsy, the result was papillary craniopharyngioma. So we use target therapy instead of doing any surgery. The volume decreased around 90%, and we sent after the patient to the radiotherapy. So the surgery was only for a biopsy. So when you look at the result in the literature, small cohorts, mean tumor volume rejection close to 90%, the response rate for treatment 100%, but there is probably a bias because only positive results are published so far. So it's very well tolerated. There is a phase 2 trial published by Brastiano at the ASCO, the meeting last year. 60 patients, it's the same result. 90% of tumor reduction volume, 100% of the patient response. So it works well and it's well tolerated. So we are collating the French case. In Lyon, we use this kind of approach for 6 patients, 3 adjuvants. It was surgery, recurrence after surgery, or recurrence after surgery and radiotherapy. And 3 neoadjuvant patients is the same, and the new strategy. I mean, there is a tumor you cannot remove. You perform only a biopsy, and if it's a papillary, you use target therapy to decrease for medical debulking before radiotherapy. So it's this kind of patient, when you, for sure, if you think that you can remove the tumor, it's the best treatment. So you operate the tumor and you remove the tumor, like in this case. But for this kind of very huge invasive tumor, you can use only a biopsy and target therapy to do a debulking before radiotherapy. And there is less morbidity using this kind of approach. So it was the last case, this tumor, papillary craniopharyngioma, 1 month after the tumor, the treatment, the target, B therapy we use, it's very an efficient and impressive result. And the patient is really doing well without morbidity. So for ACP, it's not the same story because we don't have any drugs against the mutations. So you can think about 2 kind of approach. And there is very few case published so far. In this case, it's a pediatric case, large cystic tumor recurrence after surgery, sometime after in situ chemotherapy. And they use, in the first phase of the treatment, anti-IL-6 receptor treatment, systemic approach, not local approach, not in situ approach. And after, there have some response. And after, it was not working so well. So they use anti-IL-6 and anti-VEGF systemic approach. And you can see here the tumor response in terms of volume decrease. That's really impressive. So only 2 cases. So we use this kind of approach with only anti-VEGF therapy for these patients. It was a whole patient recurrence, ACP recurrence, symptomatic recurrence, growing very fast because in 2 months he was almost blind. So we use in the waiting time for radiotherapy, anti-VEGF therapy. So after 6 weeks, you have a decrease of the cyst of the tumor. after 12 weeks, sorry, the tumor is decreasing. It's not the same result that for target therapy in papillary craniopharyngioma, but it's work, and in this case, the patient was able to read after 6 weeks. So it's work, not so impressive, but it's work, and it can be used in some occasions. Here is the tumor decrease volume in 2 months. And after we send for sure the patient to radiotherapy. So here is the table to summarize the medical treatment. Anti-BRAF therapy for papillary, it's worked very well. And after immune checkpoint inhibitor, IL-6 receptor, VEGF inhibitor for ACP. So the take-home message is for atypical PITNET, aggressive PITNET, it's temozolomide that work well. Immune checkpoint inhibitor are coming in routine. Anti-BRAF, anti-MEK for papillary craniopharyngioma, it's a new paradigm, perhaps in complex form, invasive form, only a biopsy. If it's a papillary, you can use neoadjuvant approach before radiotherapy. And now for pituitary tumor, there is a switch to neuro-oncology. The Pituitary Society promotes a pituitary tumor center of excellence. But in this kind of meeting, we have only radiotherapy, radiotherapist, endocrinologist, neurosurgeon, and now we need also a pituitary oncologist. That means that can be an endocrinologist that switch to neuro-oncology, or in the other way, a neuro-oncologist switch to the endocrinologist. But we need now neuro-oncologist in our team. Thank you.
Thank you so much, Emmanuel, for this nice overview of the medical therapy that are available in aggressive PITNETs and craniopharyngiomas. I think all of us should be aware of that, and it changed completely the treatment of such patients. I know you have other commitments right now, and I don't see any question in the chat. So
okay.
I just would like to thank you again for being with us.
Thanks to all, and sorry, but I need to leave.
Bye-bye, Emmanuel, and thank you again.
Thanks.
So, I'd like to move to the talk of Julia Kozu, working in Lausanne with a very active member of the skill-based section as well. So, Julia, it's our pleasure to give you the floor to speak with us about PD-L1 expression in PITNET. Please.
Thank you very much. I will share my screen. Just okay. Should be good. Okay, so good afternoon to everyone. I'm very happy to be here and to be able to speak about our project on PD-L1 expression and features of aggressiveness in PITNET. So this project was started some years ago, and it was possible thanks to a founding of the ENS in 2020. So thank you to you for the support. So I will connect a little bit to Emmanuel's talk. Actually, what we know on PITNET is very few about their clinical and biological behavior. We know that most of them have a benign behavior, but more or less 10% of them may have some aggressive features. So now, how we can define a tumor as aggressive? As previously Emmanuel said, it's a radiologically invasive tumor that grows very fast or that doesn't respond to optimal standard therapies. So the PITNET classification changed a lot during the last 20 years, more or less. In 2004, we had this category of atypical adenomas. So they were in between typical adenomas and carcinoma. And then in 2017, we had these high-risk pituitary adenomas. So this category of atypical adenomas disappeared. And now in 2022, pathologists concentrated on the classification according to transcriptional factors, and they are just keeping some aggressive subtypes, such as sparsely granulated GH and then densely granulated prolactin or Crook cells tumors, as you know. So now what we know from our pathologists is that we don't have any morphological criteria to distinguish between locally aggressive tumors or pituitary carcinoma, except when we have metastasis, of course. So the most commonly used classification for PITNET is nowadays the TRUIAS classifications, that is separating the tumors in invasive tumors and non-invasive according to the invasion of sphenoid sinus and cavernous sinus. And then we classify the tumors according to their proliferative factors that they express at immunopathology. So P53 typically, mitosis, and then Ki67 expression. So nowadays we know that this category of tumors that are aggressive can be quite delicate situations, because sometimes we need to perform more aggressive surgeries. We have to address also some portions in the cavernous sinus or in the subarachnoidal space. And then some of these patients can also benefit from early radio and chemotherapy. About 30% of patients are also resistant to temozolomide. And we are also directing towards new therapies like immunotherapies, for instance. So we decided to concentrate on immunotherapy concerning PD-L1 expression. So as Emmanuel said before, PD-L1 is a molecule that is expressed on tumor cells and that can allow these tumoral cells to evade the immune host system. So actually the tumor can escape the immune response and can continue to grow more and more if it expresses PD-L1. What we know nowadays is mainly from lung cancers, and we know that tumors with high levels of PD-L1 expression have a more aggressive behaviors and are most likely to respond to immunotherapy, of course. How we can measure PD-L1 is by immunohistochemistry. So we measure the portion of tumor cells that express PD-L1. And this is called commonly TPS. We know that when TPS, so when PD-L1 expression is higher than 50%, we could have a benefit in treating our patients with checkpoint inhibitors. So now what we wanted to know with our projects is if PD-L1 positive tumors are associated with a more aggressive feature also in the PITNET cohort, because this isn't clear at all in literature. So we decided to analyze through a retrospective analysis our surgical cohort of PITNET to search for a relationship with radiological invasion, immunohistopathological markers of proliferation, and also with the hormonal profile and with long-term recurrence. So our pathologist was blind to the clinical and radiological features of the tumor at baseline, and over 3 years, we could collect the data of 86 patients that accepted the analysis, because it was a supplementary analysis, of course. So half of them were women, and about 60% of our surgical series were non-functional pituitary adenomas. We had macroadenomas in more than 90% of cases. So what we can see is that we had invasive tumors, so CNOSP 3 or 4 in more or less half of cases. And then also with histopathological diagnosis, we had gonadotroph tumors in about half of cases. So some of them expressing G8, FSH and LH, and others were only expressing the transcriptional factor SF1. And then the other big cohort was of somatotroph tumors. The other functioning tumor were less frequent. So what we found in our cohort, it was that our best cutoff at which we could define if a tumor was proliferative or not proliferative, it was when we set a cutoff of 30%. So when we had tumors expressing more than expressing PD-L1 in more than 30% of cells, these tumors were highly likely to be aggressive. And this is represented in this graphic, where you can see that the proliferative grades of TRUIAS are on the right, the non-proliferative are on the left. And you can see that TPS superior to 30% was highly represented in the right cohort in the proliferative cases. Instead, we couldn't find any association between PD-L1 expression and cavernous sinus invasion or KNOS grade, as well as with the size or with the bone erosion or infiltration of dura mater. Besides Truja's classification, we could find a strong correlation with the expression of P53, but this result was not correlated with the expression of mitosis with the expression of Ki67. Instead, for hormonal expression, we could see that there was a positive correlation between PD-L1 expression and GH expression, so meaning that somatotroph tumors have a tendency to express more PD-L1, and instead an inverse relationship was present with gonadotroph tumors. So LH and FSH tumors have a tendency to express lower levels of PD-L1. So this was a case that came to our outpatient clinic. It was a refugee that came some years after the onset of her symptoms. So she had a florid acromegaly, and here you can see this MR that shows this pit net that has a large supracellular extension, and then also going infracellular, invading completely even the clivus, the sphenoid sinus, and the tumors is almost coming to the nasal fossa. So we operated this patient, and on the right you can see the result. It was packed with some fat. The exeresis, the resection was not simple, but we could deal with that, and then we packed with some fat because we were scared of having some CSF leakage after surgery. And our pathologist told us that it was a tumor, a sparsely granulated GH, as we could maybe expect, and that the TPS was quite high, so it was more than 30%. This was instead a second case, always a young lady that came with, again, features of acromegaly, not so advanced as in the first case. And here you can see in the superior pictures the images of the tumor that is in the sella with a small supracellular extension on the left, and then the normal pituitary is displaced on the right. And then inferiorly there are the postoperative pictures where the pituitary gland already took her place, and then the tumor is no more there. So the pathologist told us again that it was a GH expressing tumor, but that the PD-L1 was very low. When we analyzed a secondary outcome, the recurrence, we couldn't find any association between PD-L1 and recurrence, but I mean, this result can also be biased, as we had only 12 cases that experienced a recurrence over our follow-up period. We had a specific case of prolactin secreting carcinoma that presented with a basifrontal metastasis and an epidural lumbar metastasis too. And then the TPS that we could analyze, it was already in the metastatic tissue, and it was 0%. Actually, this is a thing that is described in metastasis. As we have a hypermutation of the tumor, in general, they lose this expression of PD-L1. So we could say that a high expression of PD-L1, defined as more than 30% of cells expressing it, may indicate that PITNET may evade the immune checkpoint and thus proliferate faster. And in our series, we could thus identify with this cutoff proliferative cases, but we couldn't find any relationship with radiological invasiveness instead. And then a higher expression of PD-L1 was instead found in somatotroph tumors. So now the question is when to consider also a tumor as invasive. I think that for the case on the left, we don't have any doubt it's an aggressive tumor that is, it's KNOS 3A in the cavernous sinus, and then it's also invading superiorly the subarachnoidal space. Instead, for the case on the right, I mean, it looks like invading the cavernous sinus too, but we should ask ourselves if the invasion of the cavernous sinus is really a marker of aggressiveness. Concerning the literature data, so we know that PD-L1 can be a potential target in preclinical studies. There are very strong studies about that in murine models. And then concerning the clinical studies, nowadays some trials of immunotherapy are starting, but Emmanuel already showed you some results, but it isn't clear if the response can be really predicted by PD-L1 expression. This needs still to be clarified. So what we can conclude is that PD-1 expression is associated with proliferative grades according to TRUIAS when it is higher than 30%. Then we also confirm that PD-L1 is higher in secreting tumors, in particular in somatotroph tumors. But of course, we need to do further research to identify robust biomarkers to predict the response to immunotherapy. So what we plan to do is to add our perspective series and also to obtain a longer follow-up to evaluate recurrence. Of course, we're open to international collaboration if you want to. So thank you to my team for their support. Thank you to EDNS also for the funding, and thank you for the attention.
Thank you so much, Julia, for sharing with us those very interesting data on the PD-L1 expression in PITNET. Maybe we can keep the question for the end of the webinar, if you agree. Your talk was very complementary to the one of Emmanuel about all the prognostic factors and medical treatment available.
Mm-hmm. A pleasure.
So now we move to the talk of Henri Schroeder. Henri, welcome. Nice to see you with us again to discuss the endoscopic endonasal resection of giant pituitary adenomas, and especially the ones with cavernous sinus invasion. We know all of us know your huge experience in that field, so it's our pleasure, Henri. Please.
Hello, Michael. Thank you for the nice introduction. It's always a great pleasure to be here at the webinars of the skull-base section of ENS. So my topic is simple. It's just a surgical topic about the approach. I hope you can see the screen. Is it okay?
Yes, that's perfect.
So giant pituitary adenomas are especially challenging because usually they grow into multiple compartments. Frequently there's this cavernous sinus invasion. They may encase major vessels. They cause optic nerve compression. And many people recommended a combined approach for these tumors. It's also the question, should we start with a transcranial approach? Should we start with an endonasal approach? Or is an endonasal approach sufficient to treat it? First, of course, we make imaging. When we see such a huge tumor, patient has oculomotor palsy and visual problems, should we run into immediate surgery, yes or no? Of course not. First, we should do an endocrinological evaluation because frequently, especially in younger patients, these tumors are prolactinomas, and then it is ill-advised to make immediate surgery. Even if they have already visual problems, the response of these tumors to dopamine agonists is very rapid. This girl was a 13-year-old girl in '93, and she received bromocriptine at that time. And you see, after 1 year, the tumor was shrinking down and she never required surgery. She has now 2 kids and had never done a surgery. So, of course, prolactinoma has to be ruled out before we start with extended approaches for these tumors. What we do is a transcellular, transplanum tuberculum, and frequently also transcavernous approach. So one example, 20-year-old male, headache, temporary double vision. Ophthalmology was good, but he had an insufficiency of the pituitary gland, and MRI shows a huge tumor and prolactin was increased. Of course, in this situation, we start first with dopamine agonists. You see here the invasion of the cavernous sinus and also here an extension into the area of the middle temporal lobe. So Dostinex was applied 2 times a week. He has substitution of his pituitary insufficiency, and you see a very good response, shrinking of the tumor. Then during a soccer game, he hit the head of the other guy, and he had severe headache, suddenly nausea, vomiting, ophthalmology was intact, but you see there was clearly a hemorrhage and the tumor was blowing up again to almost the same size. And because of his massive headache, we made the surgery. So with the transcellular approach, you see typical pituitary apoplexy. And then the problem is, if you treat a prolactinoma with dopamine agonists, frequently the tumor is very fibrous. So it's not so easy to suck it off simply, like in a virgin case, but you see we need to keep grasping forceps, curved suction. We have a 30-degree endoscope now to look to the cavernous sinus. So we have here lateral and the lateral compartment already of the cavernous sinus. And you see it's very fibrous. And so we had to take forceps. This is in temporomesial dura. And we could resect all this tumor. Here you see already fibers of the cranial nerves in the lateral wall of the cavernous sinus. So then, of course, we have to stop. But you see, we have quite done a good resection also of this area here where the tumor was extending lateral to the carotid and in the area of the temporomesial lobe. And this is done with an angulated scope. Usually we start with 30 degrees, then we change to 45-degree curved suction and curved grasping forceps. We can receive a good resection of the tumor. Of course, there is some residual tumor, but prolactin was was good controlled with just Dostinex 0.25 milligrams per week. Another case is what a 42-year-old male, headache, loss of visual acuity, visual field deficits, and you see a huge tumor expanding the cella, going supracellar. And of course, in these tumors, it's not sufficient to make a transcellular approach. You need to do an extended transplantum transtuberculum. And these tumors, we always would start with an endonasal approach because you never know how is the consistency. Sometimes all this tumor can come down. You see the encasement of the anterior cerebral artery complex. So it is even behind the perforators of the anterior cerebral artery. And you see here we have a 45-degree endoscope, curved suction, and we remove the tumor as much as we can, but behind the perforators, we left a little bit. So now the approach is extended to a transplanum approach. And you see here the frontal lobe comes in, again, curved suction. And this tumor was suckable, so it was easy to remove. And you see the dead space is filled with fat, and then the nasal septal flap is placed. And you see here is a small residual tumor, but this is just followed. It's now 5 years after surgery. So you see the resorption of the fat, just the flap is there, and this tumor here behind the anterior cerebral artery complex, we just left it, and you see there's no growth. So it's very frequent that sometimes even the remnants of these tumors shrink down because we cut all the small vessels which supply the tumor. So it's no need to go immediately or to make radiation upfront, in my opinion. And this is another case. This is the largest tumor what I have seen in Germany here, 73-year-old female. She came in with pituitary insufficiency, almost Edison crisis. Cortisol was very low. She was sleepy, confusion, and she had the right hemiparesis. And then you see a tumor, but we usually don't see in Germany. It's like a tumor from India. It's a huge tumor. But also in this case, we started from the endonasal part because sometimes the tumor comes down. So we never put a lumbar drain. So we want to have a little bit pressure. So that the intracranial pressure is pushing the tumor into our resection area. And you see here the compression of the midbrain on the side. So this is a case for an extended endoscopic approach. You see here again, T2 weighted image, hydrocephalus was already present, and you see this compression of the midbrain in this area. So we make a wide opening. You see the optic nerve on the left side, optic nerve on the right side. So first we start with a transcellular approach. Fortunately, the tumor was not too firm, could be sucked, and with a curette we could resect it. So first The intracellular part is resected. And then you see a remnant of the pituitary. You see, this is a right optic nerve. Now we make the extension to an expanded approach, and we remove the tumor which was compressing here, the optic nerve on the right side. This is already all intradural. So remove this tumor part. And then when you look to this is a right optic nerve, and you see the pressure of the tumor against the optic nerve pushes the nerve to the anterior cerebral artery. And because of the pulsation, the right nerve is almost cut completely through. That's why she has this severe visual loss on the right side, because the pressure caused the artery to hammer on the nerve and makes this severe damage to the optic nerve. This is frequently the finding what we see in these large tumors. So then we resect more of the tumor. You see, this is a diaphragma celli. So I would not resect this. This plane should remain, because above the diaphragma celli are the branches of the suprahypophyseal artery. And you should not make the mistake to cut this and damage these arteries, because then you have a poor visual outcome. So just the tumor is addressed. You see here ENT instruments, a Blakesley curved, it's dissected, and all the connective tissue is left in place. You see, it's a bloody tumor. But finally, all the tumor came down. You see 45-degree endoscope. We look up, and here we see the oculomotor nerve and the PCOM. All this part could be removed from this transcellular approach. Then, of course, fat is placed in the resection cavity, and the nasoseptal flap is used to cover the defect. And when you look to the post-op MRI, this is our fat for reconstruction, nasoseptal flap. And just we had to leave a little bit of tumor which was behind the perforators of the PCOM. So there's no need to take this out, because there's a risk that you damage the small perforators and have an infarction. Otherwise, we have a good resection, and we just observe this tumor part, and it is still stable. But of course, these large tumors have the potential for complications. This was a young girl. She came from Cairo. She has a hemianopsia, and she came with a diagnosis of a craniopharyngioma. And when we make the surgery, you have an immediate decompression, because this is a cystic cavity. If you cut it, you have immediate decompression of this lesion. So we cut, and you see it is not a craniopharyngioma, but it's a cystic pituitary adenoma. But nevertheless, you see it's a cystic component, and immediately the fluid escaped from the cavity of the tumor. And then we dissected around. We never crossed the border of the dura. We just removed the tumor, which was clearly seen and could be differentiated from the normal gland. You see here, this is a kind of a pseudocapsule, which we can't use for dissection. You see here, this is a normal gland. You see here, this is a normal gland on the diaphragma, and here is the tumor. So it was a clear plane. So we resected the tumor along this pseudocapsule, and then she deteriorated in the night. And you see our nasoseptal flap was covering the defect very, very nicely, but a small hemorrhage could not escape into the nose, but blew up the resection cavity. So we had to come in the night and make another resection, because the visual acuity decreased pretty much. And then we made post-op MRI shows now a good decompression. Then she was doing okay. She improved in the vision. And then around 6 days after surgery, she developed a hemiparesis. So my guys made a CT scan in the night and said, no, there's nothing wrong. Everything looks good. And then in the morning, they called me. I said, no, we have to make, you have to make an MRI to look what's happening, perfusion scan. And you see in the MRI, you see there is blood outside the resection cavity. So because of the decompression of the cystic cavity, there was obviously a rupture of a small vein on the capsule of the tumor when it fell down. So we never saw this during the surgery because the dura was intact. The diaphragma was just extended but was not perforated. But this blood then causes obviously hemophageal vasospasm. And you see here in the perfusion, you see there's a deficit on this side. And so then our interventionalist went in and saw a severe stenosis here of the carotid and also the anterior cerebral artery. They made an angioplasty, and then she immediately improved. That was good. And then when she was for discharge, you see the tumor is pretty much removed and she's improving in the visual acuity. Left side was okay, right side was a little bit worse, but better than before. And the visual field on the left eye improved, on the right eye remained stable. So this can happen. So it's rare that you have hemiphageal, that you have vasospasm because of bleeding around a large pituitary adenoma, but you should take this into consideration. Another complication, what can occur is when you leave a major remnant of tumor behind. So this was a 74-year-old male. He had psychological changes, fatigue, loss of visual acuity on the right eye. On the left eye, he was already blind since childhood. But he was on a drug-eluting stent with ASF and Plavix. Of course, this is a risk factor, although we stopped it shortly before the surgery. And you see, the tumor is extending into the third ventricle. When we made the resection, it was easy to remove this, but this piece came not down. So we tried with curved forceps and everything, but this tumor piece came not down. So we stopped it and had to leave the intraventricular part of the tumor. And then in the night, he deteriorated. And you see, he developed massive hydrocephalus because of hemorrhage of the residual tumor. And this happens in our series twice, that we have two patients which deteriorated after we have left a significant amount of tumor behind in a critical area. So then we came in with a lot of ventricular scope. We came in from the right frontal borehole, and then endoscopically, we removed this tumor from the third, endoscopically, we removed the tumor from the third ventricle. But this, if you have a macroadenoma and you have the feeling that you left a lot of tumor behind, it's better you add immediately a second surgery, transcranial approach, or like here, an endoscopic approach to remove this tumor piece to avoid that you will be waked up in the night and you have to make an emergency surgery for this case. So most of it was removed. Of course, at the floor, we stopped to avoid any damage. You see the floors coming now into view, and then we just coagulated the margin and left this behind. But you see, we could remove almost all. A little bit tumor is left at the stalk. Otherwise, the tumor is pretty much removed. And he's now, I don't know how, at least 6 or 7 years after surgery, and he's still doing okay. So this was an evaluation of the last 15 years or so, where we had our series of tumors. And you see in Germany, at least, the number of giant pituitary adenomas is rare. We don't see it very much. It's different to other countries where patients come late. Usually we see only small tumors. And we had 8 non-functioning adenomas, 1 growth hormone secreting, ACTH secreting, 1 prolactinoma, and 1 combined adenoma. Mostly they come with visual field problems, endocrinological deficits. And of course, most of these tumors, you cannot get a gross total resection because they grow in the cavernous sinus. But you can decompress the optic chiasm, so the visual outcome is quite good. Of course, DI can happen, ZIAD can happen. And this, in one case, we had this transient vasospasm, CSF leakage, but we had no visual deterioration in this area. But most of them, of course, require hormonal replacement therapy. So for the giant adenomas, first is you have to rule out prolactinomas. You have to prepare a nasoseptal flap because you expect a major CSF leakage in most cases. Extended approaches are mostly required in these large tumors to get them out. And what is very helpful is a Doppler to identify the carotid artery. and residuals often remain stable. So we don't make upfront radiotherapy. We just observe only if this is growing, we consider reoperation or to the radiation. Now we just want to show a little bit about cavernous sinus. Michael, you are too early.
No problem, Henri.
You see, when you have the microscope, when we have, this is a microscopic view with a speculum, and you see, you cannot see the wall of the cavernous sinus. So always it was a blind curettage. But if you take a 30-degree endoscope or 45, you see the wall of the cavernous sinus, and you can really remove all the tumor which is hidden in this area. So for these cases, an endoscope with angulated view is very helpful. You see, this is the anatomy, cavernous sinus. There is the carotid inside. There's abducens nerve which runs freely through the sinus, and in the wall you have the nerves of oculomotor nerve, trochlear nerve, and V1 and V2. All these structures under cavernous sinus. So this is a limitation in the resection. And when you take an angulated, an endoscope with angulated view, you can see the wall very nicely, and you can resect tumor. Can we always resect tumor in this area? No, if the tumor is very fibrous, it's ill-devised that you have scissors or a grasping forceps and pull on these structures, because you may damage them. But sometimes the tumors are very soft. And then, of course, you can look very nicely to the lateral wall of the cavernous sinus. You see, this is the area where the oculomotor nerve runs. This is the cavernous sinus carotid, is the clavicle carotid. So that for that, the endoscope is ideal. Two examples, 71-year-old lady had the pituitary insufficiency, and you see the tumor on the right side is invading the cavernous sinus. You see, this is a carotid, and lateral to the carotid, we have this tumor. Here you see it again in the axial view. Tumor is encasing the carotid on the right side. So one trick to identify the carotid early, if you don't see where it is to drill it in the clivus. So you can unroof the carotid, and you know, here's the carotid. We can take a Doppler, and then you take the Doppler here to look where is the course of the carotid, and then you can cut the dura medially. Also, if required, you can cut it laterally. The Doppler is very helpful to identify it. It's much better than the navigation, because navigation can be inaccurate. The Doppler is always very reliable. So again, first the tumor part in the cellar is removed, and then we just follow the tumor. You see, the tumor is very soft. Here comes the medial wall of the cavernous sinus. And frequently, the tumor has already made a perforation in the wall of the cavernous sinus. We just follow the tumor. Yes, you see the carotid is running here. And now we go lateral to the carotid and can remove the tumor here very easily with a 30-degree endoscope. And later on 45, you see a curved suction comes here. So we can remove all the tumor under the carotid. And you see, this is the carotid. We open a little bit more the medial wall of the cavernous sinus to get more exposure to the tumor. And then usually it starts to bleed. And if it starts to bleed, you know you have reached the segment of the cavernous sinus which is not infiltrated. Starts to bleed, and you know the tumor is removed. Again, curved suction. You can look in any corner to remove all the small tumor remnants which are here. You see, this is the carotid running here. This is lateral to the carotid. This is medial to the carotid. So if the tumor is soft, is good. It's a microvascular Doppler to check carotid. And then what is one important message is, even if you have not a CSF leakage, and we did not prepare a nasoseptal flap in this case because we did not expect a leakage, it's of utmost importance that you cover the carotid. Never leave the carotid exposed to air, because this can cause a later damage to the carotid with rupture. Giorgio Franco, I think, was the first who reported this in a chordoma case where he had a nice resection, and you saw the carotid was running free to the cavity. He did not cover it because there was no CSF leakage, but then maybe because of infection, the carotid ruptures and the patient died on the street because of massive nose bleeding. So it's very important to cover it. You see, 3 years after surgery, no recurrence, and she's doing well. Another example was the third time a recurrent adenoma in this young girl, and she had the tumor which is encasing the cavernous sinus again on the right side. She received already radiation, but tumor recurs. You see the infiltration cavernous sinus on the right side. So if you go in after this third, or it's now the fourth surgery, you see everything is scarred, the navigation is used. First, the anterior part of the tumor on the sigmoid sphenoid sinus is removed. Then, of course, we drill the skull base to expose the carotid. Again, microvascular Doppler is used to check the course of the carotid. So immediately we incise the jaw, you see a lot of scar tissue. And then we resect the tumor with curettes. This is all done under 0-degree endoscope. Here is the carotid on the lateral side. Some fibrous parts. But the tumor itself was not so fibrous. It's always good when you have a soft adenoma. And then we go now in the direction of the cavernous sinus on the right side. And with a curved suction. Again, this is the course of the Doppler, of the carotid. Check with the microvascular Doppler, and then we go lateral to the wall of the cavernous sinus. And you see with this curved suction, we could remove the tumor behind the carotid. And here with the curette, also we removed the remnants. So with 45-degree endoscope, you can have a nice look and have a good resection in this area. No CSF leakage in this case. And you see 3 months after surgery, this piece of tumor could be nicely resected. So finally, I want to invite you to our World Congress of Neuroendoscopy to be held in Singapore in November, and I hope everybody of you will join. Thank you for your attention.
Thank you so much, Henry, for showing me all those challenging tumors. And one of the key messages you also detail is when to stop. This is one important concept, and when to leave a remnant of tumor, despite you are going in very challenging areas, to show us cases where you stop, because at some point you feel uncomfortable to work, of course, with the perforators and so forth. This is very important, and also how to manage the complications, and such complications are quite rare, and it was very interesting. Thank you so much. Maybe we can discuss about the vasospasm after the talk of Luigi. I know he has also some opinion about the vasospasm after pituitary surgery. But I will let first Luigi discuss with us the topic about rare cellular lesions. He had a lot of experience in any tumors located in this area, so I expect that he has a lot of experience also on rare lesions. Please, Luigi, very happy that you join us.
Thank you. Nice to meet you. Nice to meet everybody there. I'll try to share my screen. And okay. Do you see the screen?
Yes, not yet. Yes, perfect. Full mode screen.
Okay. I will try to bring quite fast. So, you know, pituitary gland, any component of the gland, including the store, can be affected by some tumors. And as you know, inside the cell, the vast majority of the tumors are they're now called pitnet, but there is a rate of around 10% of not pituitary lesion which can be encountered. So we can have some other tumors, we can have primitive germ cell tumor, we can have some other more tumor, metastasis, inflammatory disease, vascular lesion, arachnoid cyst. So you see that there is a quite large variety of lesion, and the bad thing is that for this lesion, there are not specific imaging characteristics that can help us in distinguishing one lesion from the other. But, you know, we have to use some clinical finding, because most of the time we can have some clinical feature which can suggest for the possible nature of non-pituitary lesion, like for example some cranial nerve abnormality or an early onset of DI. We studied this rare lesion some years ago, and again, we didn't find any specific or pathognomonic finding, especially or on MRI or on CT scan. And from our series, you see that besides the vast majority of pituitary tumor, we have some more rare lesion. But when we speak about rare lesion, we have to exclude, for example, craniopharyngioma or spontaneous CSF leak or meningioma like tuberculum or diaphragma cell meningioma, because the rare lesions are other. These are the rare lesions we consider, and we have more than 100 lesions. Some of these are more frequent, some others are really exceptional. So if we go more into the detail, these are some examples of rare lesion which we can find primarily inside the cell or as a secondary extension of lesion from the supracellular area or paracellular area involving then the cellular lesion. For example, one of these is the lymphoma. Very rarely we can find isolated lymphoma inside the cell. We can have hypothalamic hamartoma. Even in this case, more frequently they are along the hypothalamus, and it's extremely rare to find an involvement of the cell with this tumor. Then we have rare tumors arising from cell waste, like for example Radke-Cleft cyst, but even epidermoid or primary tumor on the posterior part of the pituitary gland. These, for example, like pituitoma or spindle cell oncocytoma or granular cell tumor, sometimes can mimic infundibular lesion, even like craniopharyngioma. The difference that for this tumor, diabetes insipidus is quite uncommon. But this tumor has to be resected, and then they have to be submitted to radiotherapy because it's not so rare to have a recurrence from this tumor. Radke-Cleft cyst, this is yes, not extremely rare. We can find quite often, especially in large series. We have to be honestly quite conservative with this lesion, especially when they are just with a few symptoms. And what we have to do is just to empty the contents of the cyst. We have to try to avoid to resect the capsule, especially if it's adherent to the normal pituitary tissue. And even when they arise in the supracellular space, we have to resect just a limited part of the capsule. This to avoid to injury some perforating branches, especially the superior hypophyseal artery. Sometimes they can be quite large, like in this case, and they have to be distinguished by other cystic lesion. And one advice is to start to do a small opening. You see, this is the typical contents of and appearance of the fluid of the Radke, and that's all. You don't have to do any other surgical maneuver, and you see you can have a nice decompression of the optic pathway. But when you have to deal with the cystic lesion, is not always easy, because you have to try to recognize among the different possible cystic lesion, like cystic pituitary adenoma, like arachnoid cyst. And when you have arachnoid cyst, you have to try to understand if the cyst is communicating or not with the subarachnoid space. So one advice is to start with a small opening at the beginning, and then to explore with the endoscope the cellar cavity to understand what do you have in front of you, and then to tailor the next surgical maneuver according to the diagnosis you have. If you look, for example, this small lesion, this cystic lesion, I just want to show you why it's important to start with a small opening. You see, we open the cella, we open, start to open the dura with a small opening, but during the opening of this cyst, you see that a very large CSF leak appear. This because despite the size of the cyst, you have continuous refill of the cellar cavity, because this was a communicating arachnoid cyst, which are horrible. This means that you see carotid artery, you see the defect through the diaphragm. So when you have a situation like this, you have to carefully reconstruct layer by layer completely the defect. So we can have, of course, beside this, also inflammatory disease, which are quite rare, but it's not so rare to have, for example, to see some hypophysitis, which are not so rare, especially during pregnancy or after the partum. You have to recognize and discuss, as usual, with the neuroradiologist, the possible diagnosis. You have especially to see for the pituitary stalk. This patient do not require any surgery. It's just enough to give to them some steroids and hormonal replacement, and they will and the disease will be resolved. Then we can have this more rare lesion, the metastasis. And when you have metastasis, the onset usually is with the eye, and the origin is most of the time from lung or breast. And as usual, you have to check for the history of the patient, because of course they are oncologic patient, and also the onset is quite rapid. And also the shape of the cell, you will see that is quite normal, because the rapid growth of the tumor, and also the invasion of cavernous sinus and the bone erosion is quite rare. So through the transsphenoidal route, you can confirm the diagnosis. But what you have to do is not too much. You see, because the structure is not displaced, so the only thing you have to do is just to do a small debulking inside, not too much, because everything is infiltrated. We do intra-op consultation just to confirm the origin of this tumor. And once you have the confirmation, you have just to check for the hemostasis and stop your job. Also, the chiasm was a little bit decompressed, but then this patient has to be sent to radiotherapy. There are different ways to do radiotherapy. What we usually recommend is to hypofractionate the treatment with the stereotactic radiotherapy, because this hypofractionate fractionation of the radiotherapy gives the chance to reduce the side effect, especially on the chiasm. I will not speak so much about germinoma or teratoma. You know what is the surgical strategy. In almost all the cases, there's no need to have any confirmation with the surgical removal, especially through the nose, and also about the therapy. You know, not always is easy to recognize and to distinguish exactly the origin of the lesion on the MRI. And there are sometimes a lesion which we define chameleon, which give the impression to be something else, but when we operate, then they appear completely different. This is one example. You see this 46-year male with quite a rapid onset on this symptom, especially with the visual defect, which was referred to us with this MRI, which the radiologist supposed to be a craniopharyngioma. So the patient was sent to us. If you look, the enhancement of the peripheral of the lesion was looking after the surgery, say yes, it could be, but not sure. So we operated nasally this patient. We opened the planum, and you see, since the beginning, you see that the appearance was not typical for a craniopharyngioma. There was some infiltration of the infundibulum. There was not a clear plane like we usually see with the craniopharyngioma. Anyway, we start to debulk from inside, and you see this cream-like tissue coming out. Also because we had to decompress the optic chiasm. We obtain some sample for the definitive diagnosis, and then since we had no plan, we stopped the surgery because we feared that this was something originated from the brain. So we wait for the confirmation because we had not the chance to do intra-op consultation, and the initial post-op was quite good, or even with improvement of visual function. But later on, the patient developed hydrocephalus, so we had to put a biventricular peritoneal shunt. But at the end, this was the diagnosis. It was a GBM, wild type. But then the patient was sent to the STUP protocol, and he survived for around 9 months. So just to say that when we suspect to deal with a rare cell lesion, we have to consider prior history of malignancy, of infection, and we have especially to see the rapid onset and progression of the symptoms, because these very rarely belong to PITNET. Also, the eye has to be suggestive for something which is not common inside the cella. Also, cranial neuropathy or ophthalmoplegia. These are all signs or symptoms which not commonly belong to the pituitary adenoma. And also summarizing, even if you look on neuroradiological things, the thickening of the pituitary stalk or the involvement of the posterior pituitary or the loss of a high intensity signal from the posterior pituitary have to be considered something of suspicious for rare cellular lesion, or if you have some strange enhancement or sclerotic change around the cell, these are suspicious of non-pituitary lesion. Today we have the chance to use also radiomics which most probably because the machine learning process will give us the chance to overcome the limit of the MRI sequences, and this could be an additional value in the future. We have tried to use this to distinguish the consistency of pituitary adenoma, and you see that the occurrence is quite good, and most probably with a huge database on rare cellular lesion, we will be able to distinguish more easily one lesion from the other. And of course, when you deal with this lesion, you cannot rely on only on surgery. You need a multidisciplinary team, because some of these belong to the oncologic field, and so this is the reason why it's mandatory to discuss in a multidisciplinary team. This is my last slide, and thank you.
Thank you so much, Luigi, for discussing with us those rare lesions and giving us some clue to detect them preoperatively. Of course, this is also an important concern. So we will move to the last talk. There are some challenges when treating children and teenagers, but also elderly people from pituitary lesions. So it will be very interesting to listen to you, Diego, please.
Thank you, Michael. Thank you all. I am very happy to share with you our experience in pituitary surgery in elderly patient. You see well my presentation?
Yes, perfect.
Okay. Okay, I have no conflict of interest to declare, but I don't know if a conflict of interest, but don't forget the average age of the EU population on 1st January 2022 was 44.4 years. And Italy, unfortunately, is on the top of the ranking at 40 years old. And Italy, it's also come the first of the last countries with the highest ratio between elderly and people working age. Source is Eurostat, so probably is a big problem for us because the age of our patient increase, and we have to be able to manage also in the elderly patient. We start with a case. This is a man, 69 years old, affected by depression and myocardial infarction, edema, diabetes, dyslipidemia, hypokalemia, high blood pressure, unresponsive to triple antihypertensive drug therapy, worsening back pain. It was the first symptom, and the patient was addressed in the emergency with the T7 pathological fracture, moon face, truncal obesity, obviously, it's good, a smoker too, and body weight 90 kilograms. We address in our department, we start with the plasma corticals and the HETH. It was very clear for our endocrinologist. We are in front of Cushing disease. We performed MRI, showed a pituitary macroadenoma with the important supracellular extension with invasion of the inferior part of cavernous sinus according to 3B grade of Knopf's classification. But this is not the whole problem, because obviously the pituitary pathology will combine two different aspects, the metabolic aspect and the tumor lesion. So we have to be managed, sorry, both aspects of this type of pathology. First of all, it was admitted in our pituitary unit, and we start with anesthesiological counseling because the pain was very important, and we use the painkiller therapy with Durogesic. Endocrinological counseling, we start with the methirapone drug therapy to allow reduce the metabolic impact of this type of pathologies. And the cardiological counseling stopped us to the procedure because the risk of cardiological complication were more higher than surgical procedures. So we attempt with using the medical therapy, and also we contact the ophthalmological colleagues to try to control the COPD with the medium high risk surgical risk. So the problem was not the surgical procedure, the problem was the patient. And this is the multimodal therapy, multiple strategies. First of all, vertebroplasty to control the fracture of the T7 with the vertebroplasty performed by our neuroradiologist. And we start after 10 days, almost 2 weeks of medical therapy to permit us to prepare the patient to the procedure, the surgical procedure. The main problem was we have not the gold standard, the radical removal, but we know very well, as Henry Schroeder showed before, the main problem remained the top of the tumor, located very narrow in the third ventricle, and we scare of the swelling in case of you leave the remnant, and the remnant could be infested by the blood, and causing hydrocephalus. Whoa. According to surgical strategy to remove extracapsular tumor, we decide to use the transsphenoidal transtuberculum approach. As you can see very well, the optic nerve, optic carotid disease. In this phase, the surgeon removed the bone of the tuberculum, and we start with the opening of the sella turcica after removing also the suprasellar part. As you see before, the consistency of the tumor is crucial in this type of a surgery, and the tumor almost was suctionable by the aspirator, the suction tube. And as we work very well, this is the Liliequist membrane opening. You can see the tip of basilar artery, and we remove as much as possible. We use also the Doppler to check the real position of the internal carotid artery and move on in the cavernous sinus to try to remove as much possible. At the end of the tumor removal, we can explore with the angular instrument, angular optics, and telescope, and we try to remove as much as possible. This is the surgical field. We closed with a multiplier free flap, and this is the closure. The results was very positive because we remove radical the tumor, macroscopically radical, with preservation of pituitary stalk and the pituitary gland. The histopathological issue confirmed was ACTH, secondary pituitary adenoma, with a very, very low Ki67 index level, less than 2%. We observed, we are very lucky, it was not the goal of the surgeon, but was very important. We allow the wide role of cortisol, and we start with the early substitute therapy. We didn't observe any surgical complication, but the medical complications were a lot. Fever, pleural effusion, persistent edema of the lower limbs, venous thrombosis, and requiring the transfer to internal medicine department, resent to domicile after 30 days to admission. The case is very, after 5 months of follow-up, we observed the radical removal, pituitary function preserved, absence of neurological hypothalamic deficit with control for back pain without any drug therapy. Obviously, there is 2 main topics, the age and the frailty of our patient. In this paper, very, very optimistic, maybe more, maybe very, very optimistic, the author conclude that, affirm that frailty should not be seen as a barrier to successful surgical management of pituitary adenoma. But in another paper published in 2022, the authors observed that in the patient with the age of more than 85 years old, the 30-day mortality, the percentage of a 30-day mortality, 90-day mortality, and length of stay more than 5 days is more higher than the other patient, also in the elderly patient, as you can see very well. And in this cohort of patient, the percentage of cross-arterial resection is lower than the other group. What does it mean? Obviously, frailty is not a complete contraindication, but if you are in front of the 80 years old, you are very attentive and you plan very carefully your surgery. In conclusion, the statement of this author is very, very hard because they affirm that the real-world outcomes are substantially poorer than those previously reported in the literature. And they affirm that this risk may be mitigated if the patient treated in high-volume center. As most important that the patient was addressed in the pituitary unit or in the department where all the colleagues, all the specialties work together around the same patient. If you compare the age and the frailty in the same time, in this very interesting paper published 1 year ago, the authors observed that the frailty was a really factor that could be influence the results of the surgery. In conclusion, is not the advancing age, but it was the frailty that could be as more important in case patient not only so very elderly. In our example, in the case I showed before, the patient was 69 years old, but the pathology created a real frailty patient. Our series, we collected 229 patients with the age higher than 65 years old. The large part of the tumor was the null cell tumor and the gonadotropin on pituitary adenomas. In very few percentage, the other, histotype type. There is no prevalence of gender, and the large part were obviously macroadenomas. This is the age of the surgery. Our series, the large part of our series is located between 65 and 75. We observe just 18 patients with 80 years old. This is the median age for different pituitary adenomas. As you can see, the gonadotropin and the null cell are the more higher, as you see before. And we observed, it was very interesting, that in this type of patient, we observe very rare invasion, real invasion of cavernous sinus. We observe the grade 3A, 3B, and 4 in only 20%. The large part, the majority of pituitary adenoma affected in an elderly patient, more than 65 years old, we observe a just compression of the cavernous sinus, but not real invasion. Our results in non-functional pituitary adenomas, the entity of a resection was good, allowing a gross total resection in almost 80% of our cases. This was the results in functional pituitary adenoma. We are able to control a large part of the patient affected secreting pituitary adenomas with a median follow-up of 52 months with the median 47.3. And this was the results in visual impairment. As you can see, we observe a good results in a larger percentage of patients affected by preoperative visual disturbance, as you can see, and we observe any ophthalmological complication. We observe, I'm sorry, but I'm not able to show you all the series. We observe in only 174 patients. We have the results. We observe a post-surgical diabetes insipidus in 7% of our cases. Contrary, the pituitary function worsening after surgery was almost 1 year of our patient. This is the most important because the patient, in an elderly patient, is most frailty for the pituitary function after surgical maneuver. Surgical complication, 1 case of epistasis. We observe in overall 6 cases of a CFS lake requiring a second procedure, but we observe only 4 in a normal standard transphenoidal approach, and we observe 2 in extended transtuberculum series. No ophthalmological complication. It's a safe and effective surgery, but it's not with a 0 mortality. Unfortunately, we observe one perioperative mortality for anesthesiological complication and comorbidities, 0.39% of our series. Medical complication, 2 cases of pneumonia, 1 case of pulmonary embolism. Probably the new tools using the endoscopic techniques is the supradiaphragmatic approach to try to remove extracapsular tumor, also in an elderly patient. The historical paper, one of those is published by the Federico II group in 2011, and this is our paper published from our mentor Giorgio Frank, 2013. It was clearly immediately the transsphenoidal transtuberculum approach is effective procedure, but there is a higher risk of complication comparable with the transcranial approach. And so this is a case, and a 73-year-old patient affected by non-functional pituitary adenomas. We choose to use the transsphenoidal transtuberculum approach with preserving the pituitary stalk with the good results and the 4 years of follow-up without any recurrence. Our series is, we collected 30% with 3 female, 10 men, with a median age of 71.5 years old, all non-functional pituitary adenomas. In 8 cases, we treated the recurrence of this in this series. We achieve in 8 cases the gross total removal, in 5 cases partial total removal following radiotherapy with combined approach of a surgical strategy and of a treatment of multimodal strategy. Pituitary function worsening we observe in almost more than the half part of the patient treated. 2 TF Slake, the complication, and 4 surgical failed dermatomas, 2 treated by re-op, always in endoscopic technique, 2 cases with always observation, 3 cranial nerve transfer palsy, and 1 perioperative mortality with anesthesiological complication, as said before. What is the take-home message? The same of the Professor Cavallo. Teamwork, a very important, challenging procedure. It's not enough to work alone, but it's most important to work with the anesthesiologist, with geriatrics, with the internal medicine, endocrinologist, and radiotherapists. And in several cases, maybe not the radical removal, but the partial removal could be achieved. But don't forget the risk to leave a remnant, a big remnant, because the complication, as Henry Schroeder showed before, could be very dramatic. Thank you for your attention.
Thank you so much, Luigi. I think with your conclusion, you do my job of moderator. I have nothing else to say. Nice that you be again, all of us with you. Just as I spoke before, the question of vasospasm is something very interesting after a surgery. And I think, as you show us this case, and Luigi has also some concern about the vasospasm, as I told before. So, Luigi, I would be happy if you can give us your opinion about vasospasm. What are your criteria that make you a little cautious, and what's your strategy?
Yes, thank you, Michael. I completely agree with the case Henry showed us, because that's the typical history. When you have some remnant behind, you will have the risk to have a vasospasm. So you have to check carefully the patient. If they start to deteriorate, you have to suspect this, and even before the MRI, just with the CT scan, you can go into angiography and do angiography and inject nimodipine 1, 2, or even more times, because it's the fast and easy way to try to recover this patient. But the strategy is exactly the same. And also after the infusion, we give to this patient an nimodipine infusion with the pump for some days, even in the world. In craniopharyngioma, for example, we try to prevent this with post-op infusion, regardless, even if they are fine, we use nimodipine infusion routinely. I don't know if somebody of you have the same experience in using nimodipine infusion.
Will be used indeed in case of vasospasm, yes, for sure. Yeah, we use it. And you, Henri, any comment?
Yeah, we also use nimodipine if we expect something goes wrong. Yes, we are very liberal with nimodipine. Even for microvascular decompression, I use it routinely preoperatively. Yeah.
Do you use papaverine during surgery?
For microvascular decompression, yes, but not for pituitaries, no.
No, I mean for craniopharyngioma, for extended approach, do you use papaverine if you feel that, for example, you have some spasm on superior hypophyseal artery, or if you're doing some manipulation in retrocellular space? Because this is something we do. We use a lot of papaverine infusion during craniopharyngioma surgery. And one of the last things we do before closing is to use papaverine around the chiasma in the suprasellar space.
Oh, interesting. No, we don't use it usually because my experience is when you have small bleedings and they stopped and you give papaverine, they start again to bleed. Small vessels. That is what we see in microvascular decompression. Everything looks good, and I take papaverine because I see some vasospasm, and then it starts to oozing from small areas. So in craniophryngiomas, where you have, if the craniopharyngioma is large, you have a large field where it can potentially bleed. That's why I would only use it when I see there is a vasospasm. And I also, don't need to rinse. You can just soak in a patty and put it on this vessel, which is involved in the spasm. For example, what you mentioned, the superior hypophyseal arteries. But generally, to irrigate with cranius, I have not done so far, no.
Yes. But we use just to prevent, even if we don't have any suspicion of vasospasm, we like to irrigate even with cottonade, leaving the cottonade over the chiasm, soak it with the papaverine while we are preparing, for example, the fat for some minutes. It's just to prevent. But of course, it's not demonstrated the efficacy, but I think it's not something that can hurt the patient at least.
Yeah, that's a good idea. But usually, when I would see the vasospasms, then I use it. But if I don't see it, I don't do so far.
Okay.
I don't see any question in the chat box. I just see one comment of Mahmoud Messerer highlighting the nice paper that was written by Julia, the Lausanne's team, and the ENS school-based section on giant pituitary tumors. So just
Oops, I forgot. Sorry.
It was remembered by Mahmoud Messerer, no problem. And indeed, it was a very impressive paper. Thank you, Julia, who take in charge this paper at the beginning.
Thank you to you. Thank you for the invitation and for the meeting today.
It was again a great meeting today. Thank you to all of you. Just before leaving, I put back again this invitation. All of you will participate to our meeting in Brussels, more specifically in Waterloo in September. So it will be a pleasure, and thank you again to all of you to be with us in Waterloo. And for those who want to attend the meeting, you will have the opportunity to discuss face-to-face cases with all those masters. It was my pleasure to be with you. I don't know if there is still any comment from one of you after this very interesting webinar. Many aspects were covered, from medical treatment to surgical ones. So.
Yeah, I think, in my opinion, the most interesting infos were the new checkpoint inhibitors, which will become more and more available the more mutations we recognize. And I think this is a great potential. So we have so many patients, they had already surgeries, they had radiation, And then, of course, this is the last hope that we can treat more of these tumors effectively if we have more and more information about these genetic changes, mutations, and possible treatment options. Yeah, I think this is a great future.
For
Do you
sure.
agree, Julia?
Hope so. I mean, we hope. Let's continue the analysis and then let's see what it gives. But
Yes, sure.
I agree.
So thank you to all of you guys. The next meeting will be on 21 June on another skill-based topic. It will be a pleasure to meet you again at that moment. We will have still to define the topic, but I'm sure that you will be motivated to participate in. Thank you to all of you. Have a good evening and see you soon.
Bye-bye.
See you everybody.
Nice evening.
Ciao,
Bye.
ciao.
Ciao.
Ciao.